Bismillahirrahmanirrahim. Assalamu alaikum. So in the video I can see a 3 weeks old baby who in hospital setting, non-dysmorphic. He looks ill looking, lethargy and IV cannula in situ. There is projectile vomiting, and I can appreciate there is the olive shaped mass which has been moving anti-clockwise and patient anti-clockwise, and considering this is a case of infantile hypertrophic pyloric stenosis. My differential diagnosis: intestinal obstruction, volvulus malrotation, and due to the vomiting, congenital adrenal hyperplasia, UTI, inborn errors of metabolism, and acute gastroenteritis. So the history: if it's a case of pyloric stenosis, onset, course on duration, content of the vomitus, frequency of the vomiting, and anything that aggravates the vomiting, and then feeding history. If the child is eagerly to feed and hungry all this time, and urination, amount of the pee, family history of such illness present or not. On examination, airway, breathing, circulation, vital sign, dehydration status, anthropometry, and then per abdomen examination for any feed test for any peristalsis movement is present or not, and also the olive shaped mass is present on the left side of the lateral to the rectus abdominis present, on the right side lateral to the left rectus abdominis present or not. And investigation, feed test and other investigation: full blood count, urea, electrolytes, capillary blood gas, where we are expecting hypokalemic, hypochloremic, metabolic alkalosis. And management if hospitalization, NG tube suction, and IV fluid. If the child is dehydrated, then fluid will be 175 ml per kg per 24 hours, 0.9% sodium chloride with 5% dextrose, and 10 millimole potassium chloride per 500 ml fluid. If the child is not dehydrated, so the fluid will be 150 ml per kg per 24 hours, normal cell, 0.9% sodium chloride with 5% glucose, and add potassium chloride 10 millimole per 500 ml fluid. And then add the fluid, if the fluid that comes in the NG tube suction, and gastric lavage, and replace with 0.9% sodium chloride. And repeat electrolytes when the potassium is more than 3.5 millimole, bicarbonate less than 28, and chloride more than 100, so it's stable for operation. Here we will involve the pediatric surgeon, our consultant, and the support team if needed. And then after operation, post-operative fluid management will be 150 ml per kg per 24 hours, 0.9% sodium chloride with 5% dextrose, and feed can be started after 4 hours, and discharge can be given 24 to 48 hours. Minor bleeding may result, but there is no need for follow-up. Thank you. Assalamu alaikum. And other investigation, if asked, ultrasonography may be needed. Here the ultrasonography, caterpillar sign is present, pyloric thickness more than 4 mm, pylorus length more than 17 mm. In the barium swallow, there may be string sign is present, and in X-ray there is string sign, and in barium swallow there is mushroom sign is present. And here the medication history is important, taking any erythromycin or not. That's all about infantile hypertrophic pyloric stenosis.